So recording has started, okay? Recording has what? Started. So good afternoon, everyone. My name is Dr. Clinton Oha. I am a GP based in the southeast of England. I am the founder of Native Medical Education. Now, as a bit of background, I hold both the MRCGP, of course, and also the MRCS. So that's the membership of the Royal College of Surgeons. Now, over the past year, I've been dedicated to teaching and supporting candidates through the SCA exam. In that time, we've had over 1,000 students come through our program and we have seen tremendous success. Today, I want to give you a quick introduction to the SCA, what it is, why it matters, and how you can prepare effectively. So please listen and follow me. This is very important. So, whether you're just starting out or you're deep in your revision, this will help you understand what is expected of you and how to approach the exam. So, let's dive in. So, as you all know, right, the SCA is one part of the MRCGP exams, and there are 12 case stations in the exam, which each station lasting 12 minutes. But of course, if you have reasonable adjustments for any learning needs, such as those with ADHD or you have dyslexia, maybe you will have extra time. So, please, if you have any learning needs, or any needs at all, please make sure that you apply for reasonable adjustment well in time so that you will not be at a disadvantage. Now, you will be assessed based on some clinical groups. A patient less than 19-year-old, so basically pediatric patient, gender, reproductive and sexual health, including women's health, men's health, LGBTQ+, gynae, and breast. Now, long term conditions including cancer, multiple morbidity, and disability. Older adults, including frailty and people at the end of life. Mental health, including addiction, smoking, alcohol, substance misuse. Urgent and unscheduled. Then, of course, those who are for safeguarding. So, people who are health disadvantaged, including veterans, vulnerabilities, etc. So this patient, this group of people that need safeguarding, you might be tested on this as well. Now, ethnicity, culture, diversity, and inclusivity, you might also be tested on this, okay? And also, new presentation of undifferentiated disease. We will talk more about this. New presentation of undifferentiated disease, we will talk more about this. And of course, prescribing, they will test good prescribing as well. Investigation and results. You can be presented with investigation. You will be expected to interpret this investigation and manage accordingly. Of course, professional conversation and professional dilemma. You may encounter one of your colleagues, be it a nurse, nurse practitioner, paramedic practitioner, physician associate, healthcare assistant, carers, etc. All right. Now, from what we understand, right? From what we understand, there are three domains for marking. One, data gathering and diagnosis. Two, interpersonal skills, stroke relating to others. Three, clinical management and complexity. Now, from what we know, again, I keep saying from what we know and from what we can see, the total marks available in the SCA is 126 marks. Data gathering alone, 36 marks. Interpersonal skills, 36 marks. Clinical management and complexity, 54 marks. Oh my God. Oh my what? God. Why am I making a good exclamation here? Because clinical management and complexity has a lot of weighting. So if you fail this part of the exam, it's dangerous, very dangerous. So you should not fail or miss this part. You should try your best to at least have passes and clear passes in this part of the domain. Now, what domains of marking? Because I just mentioned clear pass, pass, and etc. We have four domains. We have clear pass, fail, and clear fail. So, from what we understand that clear pass involves 3 marks, pass 2 marks, fail 1 mark, clear fail 0 mark. But in some stations, some domains may weigh more than the others. So, for example, in a station where the management may be very vital compared to the history, it may weigh more. And in those stations, maybe management clear pass may be 4 marks. So please note that. Please note that. Now, this exam is something that you must take serious. All right? This exam is something that you must take serious. People fail this exam with 0.5 marks. Yes. People also fail this exam with 1 mark. So 1 mark, 0.5 can make a huge difference. So do not take this exam for granted, or it will take you for granted. Exam is how much? It's currently £1,180 at the time of this recording. However, we gather from the information that from September onwards, it's going to increase to £1,207. Pounds sterling, not dollars, not euros. Okay? Great Britain pounds. So what's that telling you? £1,207, what can that do for you? It can take you to Maldives, Qatar. Lovely, lovely, lovely what? Lovely vacation. So please do not take this for granted. Now, let us now talk what is the purpose of the SCA. The reason I'm talking about the purpose of the SCA is if you understand the purpose of the SCA, then you understand what they are looking for. The first thing they're doing is they want to assess independent practice. What does that mean? You are judged as a consultant level general practitioner. So you're an independent senior decision maker in primary care. So some people think that this exam is just, it's just a tick box. No, it's not a tick box exercise. It is not PLAB or MSRA. You are no longer a junior doctor. You are now the senior doctor making senior decisions. So you're the head in primary care. So you are going to be tested as a senior decision maker in primary care. So a consultant level in primary care, if you go to the United States or go to Canada, you're an attending physician. So at the consultant level in primary care. Now, what else? They are testing your clinical skills, your communication skills, and professional judgment. Okay? They are testing all these things. So they are checking if you're safe and ready for independent practice in the United Kingdom. So this is the main purpose of the SCA. Once you understand this, then you will understand this exam, and it will be easy for you to navigate. Now, let us now go and discuss how to approach a case station in the SCA. Now, if you look at the notes which I've given, all right, I have given a performer, but we're going to discuss some certain things here that is very important. So please follow me. Follow me because it is very important. Before each case station starts in the SCA, you are given 3 minutes of reading time. Of course, some candidates may have additional time. Those who have reasonable adjustment due to learning needs or other valid reasons. Okay, you will have what reasonable adjustment. So you may not have 3 minutes reading time. It may be 5 minutes, depending on your reasonable adjustment. Now, please, if you know you have any learning disability, or you have any learning needs, or you have any reason or valid reasons for reasonable adjustment, please apply early. Okay, apply early so that you will not be at a disadvantage. It will be unfair if you are being marked at the same level with other people. So please apply early. Now, so during that 3 minutes reading time that you have, you receive a brief description of the case. So this may include the reason for the consultation, or it may include a test result that requires interpretation. So you may receive a station where they just give to you a patient's name, age alone, and you don't know what you're expecting. All right? Or you may be given the patient's name, age, all the details, past medical history, previous history, okay? And also given the reason for coming, or you may be given what? An investigation result to interpret. So in that 3 minutes, you may be aware of what is about to, you may be aware of what you're about to see. All right, you may be aware of what you are about to see, whereas in some stations you may have no idea, and until you start the station, then you would know what the patient has come in for. So you have to get ready on both sides, and this is why we're doing this course. Okay, we're going to do introductory mock cases, talk about different cases, and you'll see how we approach such things, okay, to get you prepared. Okay, Now, in cases where the purpose of the consultation is already obvious. So, for example, if you're presented with a blood test, scan results, or investigations to interpret, the purpose of the consultation is obvious. So you can use your 3 minutes time to prepare. That 3 minutes is good for you to think about what this result might mean. What key questions should I ask this patient? For example, you're given a blood test result showing you HbA1c that is raised, showing diabetes or pre-diabetes, or you're given a blood test showing you hyperthyroidism. At that 3 minutes, you want to start to think, what does this result mean? Interpret the result. What key questions should I ask the patient? For example, let's say you have a blood test showing hyperthyroidism, and you can see from the blood test that this patient has seen your colleague. So, as you get into the station, as you're preparing for the station, you want to start to write questions you need to ask the patient, especially questions that may not have been covered from the previous consultation by your colleague. So you can say, I can see that you mentioned to my colleague that you're having racing of the heart, you are feeling sweaty, etc. Is that still the case? Has it gotten worse? Is it better? Is it still the same? And then you walk up from there. Other questions such as uh, tremors, other questions such as eye symptoms, other questions such as diarrhea, and if she's female, her periods as well. All the hyperthyroidism questions. You want to get yourself ready to ask all those questions. Family history, how has the symptoms impacted the patient's eyes, psychosocial, etc. You want to take your time in that 3 minutes to prepare so that you can have a good delivery. Now, we are all allowed to use the whiteboard. And the whiteboard is a useful tool, especially in stations like this. You can quickly jot down your structure, questions to ask, key concerns, and possible next steps. Because this helps you to stay focused and avoid missing important areas during the consultation. So, the whiteboard is just a tool to help you organize your thoughts. So, many candidates find it helpful for staying structured and calm. I did my exam in November 2023 and I found the whiteboard really helpful. It helped me to organize my thoughts very well. All right, so it's very important. Okay, it's very important. I was the first set of people. We are the first batch to write the SCA. All right, and I did amazingly well through the grace of God and, of course, through hard work. Now, let us continue to discuss more about how to use this whiteboard and why it is important. Now, some people may find that the whiteboard is helpful, some people may not find it helpful. All right, now I'll talk about for people who find it helpful. So, if you find the whiteboard helpful, I will advise that if you think you want to use the whiteboard, do not use it for the first time during your exam. No, you must start practicing with your whiteboard during your practice sessions with your colleagues, with your supervisors, right? You must start practicing. Don't try any new thing in the exam. The exam is testing what you're already used to. So do not try any new thing in the exam. Do not try any new thing in the exam. So your whiteboard can also be used to write down the explanation of the condition. Because sometimes, if you're not a native English speaker, so if English is not your first language, it may be very difficult to explain some medical jargons to patients. So you see why the whiteboard is important, all right? You don't have to be looking at it all the time. And even if you want to look at it, okay, you can tell the patient, I'm just going to jot a few things down while we talk. Hope that's okay. So it makes the interaction feel professional and transparent. Okay, so this is the essence of the whiteboard. I used the whiteboard during my exam and I found it helpful. Okay, so if it's something that you are used to, if it's something that will not distract you, I would suggest that you use it, and of course use it during your practice sessions with your colleagues and your practice sessions with your supervisors, etc. Just to help to get used to it and not to try for the first time in the exam, because that can feel very daunting for you. So don't do that. Don't try it for the first time in the exam. Please start practicing. If you want to use that in the exam, start practicing before you get to the exam. Now, what about for cases where the purpose of the consultation is less obvious? Don't worry. Your role is to explore and identify the underlying issues through focused and purposeful questioning, just like you do in everyday general practice. Some of you here do out of hours. You don't know what the patient is calling for sometimes, right? So just stay open minded and flexible. Avoid jumping into conclusions and use your clinical reasoning to guide the consultation. Like I used to say, a successful SCA consultation starts in the reading time. Use that time to prepare strategically, especially when the results or clear clinical problems are presented. The whiteboard is there to support your thinking, not to replace it. Okay? Whether the case is straightforward or uncertain, approach each consultation like a real life GP, thoughtful, structured, and focused on safe, patient centered care. Okay? You're a professional. So attack the exam like a professional. You do this every day, just like a driving test. All right? You drive every day, and of course, suddenly somebody is now watching you drive. So this is same thing for the SCA. All right? You develop good habits. The habits you develop, these habits will be useful in the exam. So start now by practicing this habit in your day-to-day practice in the surgery with your colleagues, with your supervisors, and this will get used to you. Okay? So even when the station is not obvious, the purpose of the consultation is less obvious. Use that time to get used to the patient's name. So what's this patient's name? So you want to know so that you can always call the patient by their name and develop good rapport. So very important. All right. Now, what is the performer for tackling the SCA? Data gathering and diagnosis. Data gathering and diagnosis. You start with the history, salient points and red flags, then eyes, psychosocial, then diagnosis. Listen, you must give a diagnosis to get full marks for data gathering and diagnosis. If you do not give a working diagnosis, you will leave the patient in an uncertain condition. This is not a good thing, right? And where there's uncertainty, you must explain the most likely diagnosis and give other differentials. So let's give an example. A 75-year-old male smoker, he has bloody mucus coming out from ipsilateral nose, so from the left nose, okay? And the bloody mucus has been draining from the back of his nose to his mouth. Bloody mucus draining from the back of his nose to the mouth, postnasal drip, but it's bloody mucus coming out. And he has weight loss, night sweat. This gentleman is also on apixaban for atrial fibrillation. So what are the differentials here? Number one, it could be as a result of his apixaban. Number two, he could be having sinusitis because this patient could be having sinusitis that's causing this. Also, this patient could be having what? Sinonasal cancer. So how do you explain to this patient? So you start by telling the patient, for example, Mr. O'Toole, I agree with you that sinusitis could cause the blood mucus coming from the back of your throat. I also did think that the apixaban could also contribute to it. However, I am worried that it could also mean something serious. When I say serious, I mean cancer. Cancer at the back of your throat called sinonasal cancer. You see, there are three possibilities. I've aired my thoughts. Always air your thoughts. Examiners want to hear. And the patient wants to know that the doctor knows where he is going, where he or she is going. Very important, please. Very important. So, performer for tackling the essay in the data gathering and diagnosis, your history that includes salient points and red flags, your eyes, your psychosocial, and your diagnosis. Must. All right? So, now some people ask which should come first. Should red flags or the salient points in history or the eyes or the psychosocial come first? It does not matter. It doesn't matter. So, for example, a patient comes to you and says, Doctor, I have a back pain and now this is affecting my job. You will start with psychosocial. I'm really sorry to hear that. You mentioned it's affecting your job. What job do you do? Oh dear, how long have you been having this pain? You go from there, you build up from there. It's not, you don't be formulaic. Okay? Don't be robotic. Okay? So it can be anywhere. But you must not miss the history. You must not the data gathering must contain the history, red flags, eyes, psychosocial, and diagnosis. Then what about management? Management, you must address eyes first. Address eyes first. So this, you must show that this is you are patient centered. Okay, so and the patients will feel heard, and it will make them more open to listening to and engage to any advice or treatment that you're planning to offer them. So let's say, for example, this Mr. Native mentioned that he needs a CT scan to investigate his headache because he's worried about a brain tumor. But from your history, you've realized that it's tension headache and not a serious headache. So you can explain to him, so Mr. Native, you've mentioned you were hoping for a CT scan to investigate your headache. Given that you don't have any red flag features, a scan at this stage may not show anything useful and will expose you to unnecessary radiation. How about we explore some other management options for now? And if things don't improve, we can revisit the idea of a scan. How does that sound? Do you see? You don't just go starting to tell the patient, oh, coming first face to face, I'll examine the nerves of your body, I'll look at the back of your eyes, is tension type headache, blah, 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 blah. No! Address the patient's eyes first, his agenda, health beliefs. Very important. Okay? Very important. So, management, you start by addressing eyes first. Next is investigations. Always think, is there any investigation needed? All right? Because sometimes, even when you're giving a blood test, there might still be further investigation needed to do what? To aid further diagnosis and rule out other suspected differentials. So, let me give an example. You are offered a full blood count that shows only a full blood count in front of you that shows microcytic anemia. HB is low, MCV is low. Of course, there are a lot of things that causes microcytic anemia. There is lead poisoning. There is anemia of chronic disease, even though anemia of chronic disease is mostly pneumocytic, pneumochromic, but it can also be iron deficiency. Note that, okay? So C list is the mnemonics for things that can cause what? Microcytic anemia. So C for anemia of chronic disease, L for lead poisoning, I for iron deficiency anemia, S for sideroblastic anemia, and T for thalassemia. So this C list, they can cause what? Microcytic hypochromic anemia. So if you're giving full blood counts that is showing just microcytic hypochromic anemia, you need further investigations, right? You need to do ferritin to confirm if this is likely what? Iron deficiency. So this is what I mean by thinking forward. What further investigation does this patient need? And let me tell you, investigations also include, am I bringing this patient in for face to face? For primary care, face to face to examine is a form of investigation. Blood pressure, pulse, listen to the patient's chest, ECG, looking at the back of the eye for headaches, that's fundoscopy, or a skin lesion you're not sure of, getting the patient in for a dermatoscope. It's a form of investigation. All right? Even telling the patient, can you keep a symptom diary? For example, urticaria, we need symptom diary. Okay? Abdominal migraine in a small child, you need symptom diary. Migraine, you need symptom diary. This is a form of investigation. So you think ahead. Now, the next step is treatment. The next step is treatment. So, what treatment are you offering? Are you offering a medication? If you are offering a medication, you must always check for allergies. Tell the patient one common side effect of the medication. Explain the intended duration and follow up if relevant. So, for example, you're prescribing nifedipine for Raynaud's disease. Mr. Native, I would like to prescribe you nifedipine, which can help to manage these your symptoms. Before we go ahead, can I just check? Do you have any allergies? And if it is written on the patient's note already, you don't have to ask, do you have any allergies? Because that will look like you're not making use of the information in front of you. So you say, Mr. Native, I can see from our records that you do not have any allergies. Is that still the case? Do you see that? But if there's no record of that, you can say, Mr. Native, before we go ahead, can I just check, do you have any allergies? Then you explain, this medication is typically used for blood pressure, but is also effective for your condition. One of the common side effects is dizziness. However, most people tolerate this medication well. If you ever notice anything concerning, please get in touch and we'll review it. Very simple. Name one side effect. And if the side effect is serious, for example, carbimazole, agranulocytosis, you must inform the patient. If the medication needs a particular it needs a particular way of taking the medication. For example, alendronic acid needs the patient to be upright for 30 minutes. You need to inform the patient. Levothyroxine needs the patient to take the medication first thing in the morning with 30 minutes before any other tea, coffee, or any other medication. So you need to inform the patient about this. This is what we call good prescribing. All right. So next step after treatment is health promotion. Health promotion like what? Smoking cessation, alcohol reduction, vaccines. For example, in COPD, CKD, asthma, they need flu, pneumococcal, COVID. These vaccines are very important. In pregnant women, they need what? Pertussis vaccination. They need what? RSV, COVID. So all this health promotion, you need to be aware of it. All right. Not just this. What about things like a patient coming in with they are scared they are going to get STI. You can help promote and say use of condom can prevent future STIs. All right. So very important. These are ways of health promotion. All right. Then safety netting and follow up. This is a remote consultation. This is a remote consultation. So there's going to be what? Safety net and follow up in majority of the stations. Some may have safety netting and may not have follow up. Some may have follow up and no safety netting, but majority will have both safety netting and follow up. If you give improper safety netting, you'll be marked down. If you give improper follow up, you'll be marked down. We'll discuss about reasons for failures in all these domains as very soon. So be specific. So things like if your symptoms worsen or do not improve in X amount of days, contact us or call 111. Or is it 999 in case of stroke or MI? And okay, shall we catch up in 2 to 3 weeks to see how things are going? All right. So this is very important. And then, of course, for your interpersonal skills, good explanation to the patient goes a very long way, and avoid jargon terms. So we are going to now talk about reason for failing in data gathering and diagnosis, reason for people failing in interpersonal skills, reason for people failing in what? Um, Management. Okay. So we will start with reasons for failing in data gathering and diagnosis. So reasons for failing in data gathering and what? Diagnosis. Number one, data gathering was insufficient to make a safe assessment of the situation. Now, this is a major pitfall for people, not ruling out red flags or important differentials. So never assume a diagnosis without first excluding serious or alternative possibilities. So always ask yourself, what else could this be? What must I exclude to keep the patient safe? So let's give an example. A 23-year-old female presenting with hair shedding. If you only focus on maybe topical causes like hair products or stress or recent illness, and you fail to ask about her menstrual history, you may miss iron deficiency as a contributing factor, especially if she has heavy or prolonged periods. Remember, heavy or prolonged periods can lead to iron deficiency. Iron deficiency, in turn, is a well known cause of diffuse hair loss, telogen effluvium. Okay, so this is very important. This is very important. So if you focus only just on hair products, stress, recent illness, family history of hair loss, you may miss this. So you see why it's good to think what? Think far and wide. And this is where clinical knowledge comes into place. And we will cover this in the course. So don't worry, we're covering over 120 topics or more. So we are going to cover a lot of this in the course to make sure that we give you all the details. Now, what about, and let's give another example. A 40-year-old woman is presenting with new onset amenorrhea. She has been on the POP for 8 months and had previously been having regular periods while on it. Her periods have stopped unexpectedly. Some people may focus on just the POP. The POP has a side effect of amenorrhea. So people say, oh, it's a POP, and they don't ask other questions. All right? But you need to ask, has she been taking the pill consistently? Because if she has not been taking the pill consistently, that predisposes her to a risk of what? Pregnancy. Excellent. Okay? So, Also, other things is menopause. She could be having early menopause. Yes. So, hot flushes, mood changes, these are very important. So, don't just make a conclusion, even if it's obvious. Still ask other differentials. Examiners want to see that you are thinking well. Remember, you are being marked at a level of a consultant in primary care. So, you must think like one. Okay, that is number one reason for people failing. Data gathering was insufficient to make a safe assessment of the situation. Okay, number two, existing information about the case was insufficiently utilized. I said this, for example, imagine a patient coming in and you want to ask about their allergies, but already they have written there has allergy to penicillin, and you go and say, do you have any allergies? It doesn't show that you've read the information. But rephrasing that by saying, I can see from your records, it states that you're allergic to penicillin. Is that right? Do you have any other allergies that we're not aware of? Can you see? Very important. Don't just say, oh, do you have any allergies? Whereas they have written already on the notes that you were given before you started the station. They wrote that he has allergies. So why are you asking like you didn't read them? So examiner will note this. Okay? So that is very, very important. Or the patient is on medication, for example. Patient is on medication. For example, the patient is on metformin, atorvastatin, ramipril, and you're asking the patient, are you on any other medications? No, you can tell the patient, I see your metformin, atorvastatin, and ramipril. Are you still taking those? Are you on any other medications? What of if they have already written something, the patient has seen your colleague about a condition, and they're coming to you to follow up about that condition? So you can tell the patient, I can see that you saw my colleagues a few weeks ago about your back pain. Has that gotten worse since then? Or have you experienced any new symptoms? Can you see? You are making use of the information that you have, the information in front of you. Failure to make use of this information will lead to the examiners marking you down. Please, you don't. Data gathering is the easiest part of the three domains to get a clear pass. It's the easiest part. So please don't make this type of mistake. Please. Now, let's get to the number three reason for people failing data gathering. Relevant social or psychological information insufficiently recognized or responded to. So, what does this mean? What does this mean? So let me give you an example. A patient with recurrent dyspepsia may mention that his symptoms are worse during time of stress. Now, simply prescribing him omeprazole without addressing the stress is not effective. Remember, stress is one of the what? One of the major triggers for dyspepsia. So, exploring the triggers and offering support for stress management. Example of methods for stress management. Headspace app. Headspace app is an app approved by the NHS for the management of stress. Mindfulness, meditation, regular physical activity, maintaining good sleep routine, CBT, all these things can improve their symptoms, their stress. So this is how you manage these things. Okay, so just giving this patient omeprazole will not get you the marks. All right, or a patient coming with osteoarthritis in his knee, and he is the sole breadwinner and he's self-employed. A fit note may not be useful. So you need to explore. Does he need help from Department of Works and Pensions so that he can reduce his hours? Some benefits. Do you need to refer him to the social prescriber? Okay, what about physiotherapy? Can he modify his tax? Do you see where we're coming from? So the relevant social or psychological information must be recognized and responded to. Okay, now data gathering was unsystematic or disorganized. Data gathering was unsystematic or disorganized. Now, if you finish axing your data and you're in management and then you forgot something that is very vital in the history. Let's say, for example, this patient, you need the information about their diet to advise them about diet. Let's say you're doing a station for non-alcoholic fatty liver disease and you forgot to ask the patient about their diet. And now you're in management and you want to advise the patient because you don't even know if the patient takes a bad diet. So you can, instead of just saying, can you tell me about your diet in the management? Make it professional. You can tell the patient, I meant to ask you earlier. can we briefly talk about your diet? Or, I realize I need to return to a few questions from earlier. Is that okay? Then you ask your questions. So you see, this is very important. Okay? So don't just jump. Don't just be disorganized. All right? Don't finish your history and your management and you go back to history. No. Try and be organized. You go with your history, red flags, eyes, psychosocial, explain your diagnosis, explore the eyes, then you give all your full management. All right? Be systematic. Even in asking your questions, you notice in our course, most of the common conditions, we have gone through a systematic way of asking your history questions from head to toe. For example, diabetes has a lot of complications, starting from head to toe. The eyes, diabetic retinopathy. So you ask about blurry vision. The mouth, polyuria, polydipsia and thirst. So you ask about that. Then you go down to the chest. Diabetes can cause complications such as chest pain, angina, and the rest of them. You ask all those questions. You go down and then you ask other questions such as urinary symptoms, polyuria. Then you ask other questions in the hands and legs such as peripheral neuropathy, okay, and etc. And of course, other things like diabetic nephropathy, like blood in the urine. So you go systematically asking all your questions, right? You do head to toe questions, sometimes not to forget. Okay? Now, number 5 reason for people failing, the implications of relevant findings identified during the data gathering was insufficiently recognized or understood. Now, what does that mean? You found out that a patient has dementia in your history, and you just tell the patient, oh, we'll bring you in, we'll do a blood test, we'll refer you to the memory clinic, etc. That's not all. You need to tell the patient, I'm going to write these things down so that you can take this information and you can review them just in case you forget what we've discussed today. Okay? Or I'll write this down so that you can give your loved one in case they ask you about what we discussed today. That shows awareness, the implication of what you found. All right? So, another example is a young patient with cough and hemoptysis who has recently migrated from a TB endemic region. Because he's having hemoptysis and cough, you are focusing on only pulmonary embolism or lung cancer, forgetting that TB is an important differential. If you're not mentioning TB, that means the implication of the relevant findings of him just migrating from a TB endemic region was not recognized or understood. So that is why it's important that when a patient tells you something, you should understand the implication of what they have told you. All right? So these things, we will discuss this when we take history, we do all our stations, you get all these things. Now, number 6, decision making or diagnosis was illogical, incorrect, or incomplete. Now, this is where most people get it wrong. People get worried about, oh, I have to get the correct diagnosis. No! Examiners want to see how are you thinking. Remember, you are a senior decision maker. Examiners want to see how did you come to that conclusion of the diagnosis. Did you just mention the diagnosis for fun? So let me give you an example. A female air hostess who does long haul flights, for example, Etihad, Qatar Airways, all these long haul flights that go for 7 hours, 8 hours, etc. Yeah, and she has a background history of anxiety, but she smokes, she takes the combined oral contraceptive, and then she came into you with cough, breathlessness, and palpitations. Right? Now, of course, anxiety could cause her breathlessness and palpitations. A chest infection could also cause that. Okay? If you just mention a chest infection that you think this is it, how did you miss all these important things in the history and come to that conclusion? It was not logical. So, telling the patient that based on your history, the fact that you're an air hostess, the fact that you're on the combined contraceptive pill, and the fact that you are coughing, breathlessness, and having racing of your heart, it raises a concern for a blood clot in your lungs. That shows a logical reasoning. Logical reasoning based on what? Based on the the cause and prevalence of the disease. So when you give a diagnosis that is irrelevant, or you give a diagnosis that's not logical, examiners will be angry. That's how did you come to that conclusion? And that is why it's good to air your thoughts. I keep saying this, air your thoughts. When you keep airing your thoughts all the time, especially in your day-to-day practice, telling the patient, because from everything you've said to me, you mentioned this, this, and that, I think this is this. Then you start to act professional. You start to think logical. And this will help. This will also show itself in the exam. Examiners want to think, why are you thinking this way? Even if you don't get the right diagnosis, but if it's logical thinking, then they're not worried. All right? And that differential here could be a pneumothorax. Do you see what I mean? So you need to have logical reasoning. Now, this is very important. Now, if you also tell the patient, let's say, for example, you suspect cancer and you don't give the, you don't, because like I said to you, right? You must give a diagnosis to get what? To get your full marks. Failure to give a diagnosis, even if it's uncertain, you will not get the full mark for data gathering and diagnosis. You must give a full mark. And you must not shy away from the diagnosis. So for example, so you may suspect a patient has cancer, but you're not confident enough to tell the patient they have cancer. Why? Say it. Don't just tell the patient, we'll do some tests to rule out something sinister. What do you mean by that? That is not a diagnosis. So tell the patient that I suspect you've got cancer because of this, this, and this. I'm not saying that this is definite for now, but we'll do some tests to confirm the diagnosis. So without mentioning the word cancer, it shows lack of clarity and confidence in your clinical judgment. Remember, you must give a diagnosis. You must. Okay? Right. So number 7 reason is differential diagnosis or hypothesis were inadequately generated or tested. All right? Like we all say, like I mentioned earlier before, when a patient comes in, do not jump into conclusion. Ask other questions. A young woman that collapses and loses consciousness for about a minute after standing for a long time and reports brief shakiness. She told you she's worried about a seizure activity. If you jump into seizure, you will miss the fact that vasovagal syncope could cause this. Cardiac syncope is also a possibility. Postural orthostatic tachycardia syndrome, POTS, is a possibility. So don't jump into conclusion. Ask your other differentials. Very important. Okay? Like I said to you, the best way is to share your reasoning loud. Tell the patient, you've mentioned you're worried that this might be a seizure, especially because you're shaking a bit. I understand that. All right? But seizures will involve what? Forceful, jerky movement, tongue biting, loss of bladder control, and confusion afterwards. And you mentioned that you did not have any of these symptoms. The fact that you felt lightheaded before you passed out and you recovered very quickly and you were standing for a long time makes me think that this is likely a simple faint, what we call vasovagal syncope. Can you see how you are airing your thoughts out, showing examiner how you have what? Explored the differential diagnosis. This is how I want you to deliver your history. Sorry, deliver your diagnosis. Addressing the eyes while delivering the diagnosis. Very important, okay? Very important. Now, number eight reason, number 8 and last reason for people failing history is ineffective approach or prioritization in data gathering when presented with multiple or complex problems. So, a patient presented with a 55-year-old patient presents with poor sleep, ongoing joint pains, occasional chest tightness on exertion, which is much important. Of course, the chest tightness on exertion. So if you spend your time exploring sleep hygiene and joint pain without prioritizing the chest tightness, you risk missing a serious red flag. So you can tell the patient, you've mentioned a few issues today. Thank you for sharing that. However, You mentioned about your chest discomfort. That sounds like something more serious. Are you happy that we should focus on that first? Okay, as this may be urgent, and we'll address others after we focus on that. How does that sound? All right. So you ensure you educate the patient on how urgent this is, address it, and then make sure you make an appropriate, you know, follow up for the patient for their other conditions. Okay, if there is no time. Okay, if there is no time. Now, another thing is dealing with a patient that seems to have medically unexplained symptoms. Medically unexplained symptoms. Let's give an example. A 48-year-old woman, she presents with a mix of symptoms: abdominal discomfort, fatigue, poor sleep, palpitations. Okay, they seem unrelated and they affect different body systems, isn't it? Abdominal discomfort, fatigue, poor sleep, palpitations. All right. But on gentle questioning, she told you that her husband recently passed away from cancer. And since then, she is worried that all her symptoms she's experiencing could be cancer. So she has been more anxious and she's feeling overwhelmed. So if you explore each symptom in isolation, you may risk missing the bigger picture. Okay? However, jumping to conclusions and attributing everything to anxiety or grief without proper assessment could also be unsafe. So, I'm not saying that you should not ask few questions on those symptoms. Of course, you ask few questions. The abdominal discomfort, the fatigue, poor sleep, palpitations, quickly ask few red flags on those questions that she has mentioned to you. All right? But then look at it holistically. Look at her, how it has affected her, look at her social lifestyle, and then you can tell her, look, you've mentioned quite a few symptoms and I want to make sure we don't miss anything important. So I'd like to ask you a few more questions to check there are no red flags or something serious. But I also wonder if the loss of your husband may be having a big impact on your health, both physically and emotionally. So would it be okay if we explore that as well? So you see what I'm saying? Okay, so this is very important. Don't worry, we will talk about all this. We will do cases about all this, and of course, if you have questions, please ask your questions at the end of this, and we'll address all of them. Now, let us go to the reasons for failing in clinical management very quickly. Reasons for failing. Remember, clinical management has high weighting, so failing here is dangerous, especially getting a clear fail, getting zero. Oh my God, dangerous. So number one reason, the management relating to referral was inappropriate or not reflective of current clinical practice. What does this mean? The SCA tests your ability to manage patients independently, like a consultant in primary care. I have been nagging about this ever since we started this introductory session, because it's very important that you know this. You are now an independent doctor. They're trying to assess, are you ready for independent practice? So if you refer when it's not necessary, you'll be marked down. And if you don't refer when necessary, you will also be marked down. Okay? So for example, a patient who has a straightforward polymyalgia rheumatica, referring that patient who has a straightforward polymyalgia rheumatica to rheumatology is unnecessary. And if you don't justify that, you'll be marked down. A 28-year-old man with a one-off episode of hematospermia. No red flags. Will you refer to urology? No. It's not needed now. One off. 28-year-old. And he has no red flags. Okay? Or a patient with pterygium. You know pterygium in the eye? Asymptomatic pterygium. Asymptomatic pterygium. And they're concerned about the appearance, cosmetic appearance. Will you refer urgently? No. It's not an urgent referral. It's a routine referral. But of course, if the pterygium is affecting the vision, extending into the cornea, or they're having things like inflammation in the eye, red eye, then of course this would require urgent referral. So you must know when this urgent referral is needed, routine referral is needed. Very important. If you don't know this, you'll be marked down. And throughout the course, we'll always discuss this in all topics. All right? So very important. Now, Before making any referral, ask yourself, is there something I can do for this patient right now? Okay, what am I hoping to gain from this referral? Will this referral genuinely benefit this patient? Don't just say, I'll refer. Anytime you say, I'll refer, I'm referring to the specialist will do this, this, and that. So explain what the specialist will do. By doing this all the time, you now know why you're referring and you know why you're always getting advice and guidance from the specialist. So, very important. Number two reason for people failing, the management plan relating to prescribing of medication was inappropriate or not reflective of current practice. Now, there are so many common pitfalls here. Number one, like I mentioned to you, you did not counsel the patient about serious side effects. I told you carbimazole has serious side effect of agranulocytosis. So you must tell the patient any sore throat, fever, infection, report to us immediately. All right? Not failing to check for allergies before prescription. Omitting practical advice, not explaining, for example, alendronic acid, taking it first thing in the morning, 30 minutes sitting upright, levothyroxine, or you are prescribing when no medication is needed. Okay, so you are prescribing when no medication is needed, or you're issuing things like paracetamol prescription when it can be bought over the counter, especially if the patient is able to afford it. Paracetamol is, I think, is quite cheap. It's about 50 pence or 50p, so it's quite affordable for almost everybody. Okay, unless this patient cannot afford or has no money, things like that, homeless, things like that, then of course you can prescribe. But otherwise, then there is no need. Okay, now choosing a less appropriate option. So, for example, starting mirtazapine instead of SSRI as a first line option without clear justification. I see a lot of people do this. All right, SSRI is a first line for depression. People say, oh, the patient has sleep issues, not eating. Please tell me, what are the symptoms of depression? Not eating is one of them. Sleep issues is one of them. So, addressing the depression and treating the depression, what will happen? It will solve the problem. Except, of course, if this issue with sleeping and not eating is quite serious and is concerning to the patient, then you can be justified, depending on the patient presentation. So, first line in depression is usually SSRI, except there's contraindication. For example, upper gastrointestinal bleeding. This is a contraindication to SSRIs, sertraline. So you give other medications like mirtazapine, etc. Now, not adjusting or stopping medication based on the presentation. For example, renal function. So a patient came in with EGFR of 25 and they are metformin. If you continue, if you don't discontinue this medication, you'll be marked down because it means that you don't understand the implication of that. All right, so you have to prescribe a safer alternative. So this is very important. Okay, very important. Number three, the management plan relating to investigation was inappropriate or not reflective of current practice. Okay? So, for example, you ordered a chest x-ray for a 2-day viral cough with no red flag. Why? Tell me, why are you asking this patient with a 2-day history of viral cough with no red flags? You're telling him you do x-ray for him. Why? Or you did not request an x-ray for a patient who has had a prolonged cough and red flags such as a smoker. So you see, so you should know when you should order or when you should not order a chest x-ray. I'm using this as an example. I'm using chest x-ray as an example. Oh, let's give an example. Polycystic ovarian syndrome in young females. Young females, 8 years, less than 8 years post-menarche. So for example, a young female of 17 years old, she told you she started seeing her first period at the age of 13. And she's coming in with symptoms suggestive of polycystic ovarian syndrome. For example, she's coming in with what? With hirsutism. Will you offer ultrasound? No! We don't offer ultrasound in young female less than 8 years post-menarche. Less than 8 years of gynecological age. Less than 8 years from their onset of menarche. Why? Because there's high incidence of multifollicular ovaries in this life stage. So what do you do to diagnose polycystic ovarian syndrome in this case? So clinical and biochemical features from the Rotterdam criteria may be sufficient. So do you see that if you offer ultrasound, you'll be marked down because the management plan relating to investigation was inappropriate or not reflective of current practice. Number four, the management plan relating to prevention, health promotion, or rehabilitation was inadequate or inappropriate. I talked to you about COPD, not just offering medication. What about stopping smoking? What about vaccinations to prevent the recurrence of flares, pneumococcal, COVID, flu? Do you see that? What about a 15-year-old seeking abortion? Have you talked to her about uh, contraception in future to prevent future STI, future pregnancy? Have you talked about STI screening? Do you see? Some of these things are very important. Okay? Now, the plan relating to medical management of risk was inadequate or inappropriate. Now, this part is very important, so please pay attention. Let me explain what this means. Let's give you an example. So, the plan relating to medical management of risk was inadequate or inappropriate. So, a 35-year-old female presented with heartburn, early satiety, fatigue, and weight loss. 35-year-old female. From this, what are you thinking of? Gastric cancer, right? Red flag. But gastric cancer is uncommon at her age, and she does not meet the 2-week wait criteria to be referred for urgent endoscopy. But my question to you is, will you refer this patient for urgent endoscopy? Yes. Why? The clinical red flags here, the potential risk needs to be prioritized over strictly following the guidelines. So do not rigidly follow guidelines without clinical judgment. It may compromise safety. NICE guidelines is there to guide you and not to what? Replace your judgment. Very important. Now, I've given other examples. I've given other examples in my notes. So please, let's check. For example, so another example, a gypsy traveler, temporarily registered, has signs suggesting that they need a 2-week wait referral for lung cancer. Okay? But they're living today. They are living today. Would it be safer to ask where they are heading and arrange the referral to a local service there rather than wait until they manage to register with a new GP in their new local area and potentially delay diagnosis? So you see, when it comes to sharing the documents, transferring the documents electronically is usually safer than giving the patient paper copies to carry around. So, in this patient, gypsy traveler having signs of lung cancer, and they're telling you, oh, doctor, I'm leaving today. I cannot wait. I cannot wait to get referred to 2-week wait here. You ask them, okay, where are you going to? If they know where they're going to, they can let you know, and you can refer directly to the hospital or respiratory specialist in that area directly while you transfer the records to the GP, informing the GP of what you have done. Because delaying referral to the specialist in that area may potentially do what? Delay this patient's diagnosis and, of course, increase morbidity. Do you see? So, the plan relating to the medical management of risk must be adequate and must be appropriate. Other things other things I'd like to mention are things like a family member coming to discuss a patient's care, but they have no documented permission and they're not listed as a lasting power of attorney. All right. So, would it be safe to share information with them, or could you risk breaching patient confidentiality? So, in this kind of condition, you want to take as much information from the patient relative, but you'll be careful about the type of information you want to give back. Right? So, you need to understand and weigh the what pros and cons. Now, there's so many examples. I'll give you another example so you understand what I mean. A young male coming with dysuria. Let's say this patient is 21, 22, 23, and this patient has a new sexual partner, right? And they came to you and they said, look, I have dysuria, but he's traveling abroad now. So he's calling you an hour before traveling abroad and he's asking you, what can I do? And you're saying, okay, can you come in to have a urine test? And they say they can't come in. What will you do in such situation? So it's reasonably to do what? Treat empirically. For what? STI. And what is the most common STI? Chlamydia. So you're offering doxycycline in this patient. Why? Because in this patient with dysuria, new sexual partner, at this age, male patient, you're worried about an STI compared to a UTI. Remember, UTI is not common in males. All right? But it's more common in males from 65 and above. Can you see how, clinical reasoning and management of risk is what? Appropriate. Now let's go to number 6. Number 6, the implications of comorbidity were insufficiently considered. So, what does that mean? Now, oxybutynin is first line for urge incontinence, right? But in older, frail women, would you give oxybutynin? No. You go for what? Mirabegon, right? Why? Because oxybutynin anticholinergics, risk of confusion and falls. All right? A patient who has depression, what is first line? SSRI. But if this patient has upper gastrointestinal bleeding, will SSRI be safe? Of course not. Mirtazapine will be a safer alternative. Can you see? So the implications of their comorbidities must always be sufficiently considered when you're managing this patient. Okay? For example, patient has rheumatoid arthritis affecting their hands, and they also have asthma. Will you decide to prescribe metered-dose inhaler knowing that metered-dose inhaler requires good dexterity, hand strength coordination, right? But you go ahead and prescribe a dry powdered inhaler, a dry powder inhaler. Why? Because it's more practical. It's more practical, right? It does not involve dexterity. It does not involve good hand strength and coordination. Also, this same patient in a flare, would you consider NSAIDs like ibuprofen? No. Why? Because they have asthma and this could potentially trigger their asthma. So, do you see? You always have to do what? You always have to individualize their care. All right? So, put their comorbidities into what? Consideration. Now, number 7, uncertainty, including that experienced by the patient was managed ineffectively. Uncertainty, including that experienced by the patient was managed ineffectively. So, of course, in general practice, there's always management of uncertainty, right? So, but how do you manage? Because sometimes, in some cases, the best course may be watchful waiting, safety netting, and offering clear, calm explanation and reassurance. Other times, it might be investigating, looking for possible differentials. So, a patient presents with viral symptoms for 2 days. So, in this patient presenting with viral symptoms, you want to do what? Wait and review. Will you want to do some investigation? At least you can safety net the patient. If things are not getting better, come back to us. All right? A patient with new onset mild headaches who is worried about a brain bleed, but there are no red flags. Could you consider reassurance and review in 2 weeks rather than immediately ordering a CT scan? Do you see what I mean? So the patient is saying, oh, I'm worried about a brain bleed. There are no red flags, but the patient has mild headaches. So from the history you've taken, and of course you're going to bring this patient for examination, fundoscopy, looking at the back of their eyes, etc., right? And examination of the nerves around their body, that's neurological examination, right? But this patient, you want to offer reassurance and review in 2 weeks rather than immediately ordering a CT scan. So you have to manage uncertainty, okay, using your what clinical experience and manage it safely. Now, don't worry about this. There are lots of questions we have in our mock, right? We have mock booklets over 165, about 165 cases. So we're going to discuss at least 65 of them during this session. Okay, and sometimes we do up to 70. Okay, so don't worry, we'll cover all this. We'll cover numerous cases and you understand more about these things. Now, number 8, inappropriate or inadequate arrangement for follow-up, continuity, and safety netting. Inappropriate or inadequate arrangement for follow-up, continuity, and or safety netting. If you examiners will mark you down if your follow-up plan is missing, inappropriate, too vague, or or if the safety netting is unclear, or causes anxiety, or does not reflect the clinical risk. Now, I'm going to explain. Now, a patient diagnosed with simple indigestion, and you're telling the patient, go to A&E if it happens again in case it's your heart. Can you see? Putting undue anxiety, right? Another example is a patient with suspected TIA is told to call the surgery if it happens again. Is that safe? All right. What if the next event is a stroke and the GP surgery is not opened? So, wouldn't it be safer to advise calling 999 immediately symptoms occur again? Can you see that? So, if you're safety netting a patient who's had a TIA, telling them to ring the surgery if things get bad, that is improper and unsafe safety netting. Now, a patient starting lifestyle changes for obesity, right? A patient starting lifestyle changes for obesity is booked for a review in 2 weeks. Is that helpful? Of course, there's no way you're going to lose. There's no way any human being is going to lose weight within 2 weeks, right? I mean, lifestyle changes take a while to do what? To show effect. So at least a 1 to 3 months time frame may be more realistic to see progress and reduce pressure. A patient with mild viral symptoms. So a patient with mild viral symptoms, you're not giving any safety netting advice. What if it worsens at home? What should the patient do? So simple plans. If your fever lasts more than 5 days, you start feeling breathless, please call us immediately, seek urgent medical advice, 111, etc. Okay? So it is very important that you give clear, proper safety netting and follow up. I mean, you cannot be seeing a patient with obstructive sleep apnea, and then you're telling the patient, if your symptoms worsen, call 999. That does not make sense, right? 999 is reserved for serious things like what? Stroke, MI, etc. Right? So we discuss all this as we go through cases. We'll talk about things like this, okay? Now, the last part in management, which a lot of people also get marked down for, is poor time management. People spend too much time on history. Remember, you have 12 minutes. 12 minutes. So, at least the first 5 minutes for what? For history. Or first 5 minutes, 30 seconds for history. All right. And the remaining 6 minutes, 30 seconds for management. Management is bulky. So you need to have time for management and to discuss a lot of things. All right. So very important. All right. Very, very important. Now, let us go into reasons for people failing in interpersonal skills. Reasons for people failing in interpersonal skills. Number one, communication skills, including the non-verbal, responding to cues, and or active listening, were insufficiently demonstrated. Okay? Now, let me give you an example of your communication skills or non-verbal or responding to cues were insufficiently demonstrated. For example, saying, I'm sorry to hear that repeatedly. That may feel robotic. Or a patient tells you, well, since I lost my job, things has been tough at home. And you didn't explore why. You didn't say, oh, I'm sorry to hear that. Could you tell me, when you mean things are tough at home, what do you mean by that? Right? So responding accurately, like the way you're communicating. I mean, if your wife comes to tell you, I'm so stressed out, will you tell her, oh honey, go inside and get me cook rice for me? No, you're not gonna do that. She's not gonna cook that rice. You're gonna stay hungry and you're going to sleep and go to bed hungry. So you need to ask her, honey, tell me what's going on. Right? Do you need a Gucci bag? Do you need Chanel? Do you need to go for vacation in Maldives? Do you need to go for vacation in Qatar? Do you need to go for vacation in Vietnam, in Nigeria? Etc. Okay? So, good communication. Just the same way you communicate with your spouse at home, responding to cues. But I mean, this is a patient, so you're not going to call a patient honey. You know what I mean? So, that is an example, okay? That is an example. Or a patient says, I found a lump in my neck and I'm worried. All right? And then you say, how long has the lump been there? Oh my God. The patient just told you, I'm worried. How about saying, I can see this is worrying you. Can you tell me what is most concerning for you about this lump? Right? Respond. Respond in a what? In a good communication style. All right? Show that you're listening to the patient and you're not just there to do your job. All right? So, effective communication is about curiosity, empathy, responding in a way that the patient feels heard. All right? Very important. Now, second reason why people don't do well in interpersonal skills is the patient's agenda, beliefs, or preferences not explored or addressed. Now, a patient with high blood pressure, he may be reluctant to start medication because a friend developed erectile dysfunction on antihypertensives. Now, dismissing his concern or pushing medications without discussing his health beliefs, it may lead to non-adherence. So if you give him the medication and you don't address that, he will not take it. Because no man wants to have erectile dysfunction. If not, what will happen? His wife will leave him and go where? And run away. Right? So you need to tell the patient, I understand that this is your concern. Some medications can cause a side effect, but there are other ways to lower the risk. So let's look through options together. All right? Or you tell the patient, not all antihypertensives, not everyone who build antihypertensive will have this side effect. And besides, uncontrolled hypertension will lead to what? Erectile dysfunction faster than what? Controlled hypertension. So there are ways to address their concerns and show that you're actively listening to the patient. All right. Now, so this is very important. This is very important. Now, another one is explanations were inadequately shared or adapted for the person's needs. Explanations were inadequately shared or adapted for the patient's needs. So it just simply means using medical jargon. This is an autoimmune condition. Why would you say that? Or even if you say it's an autoimmune condition, go ahead to say, by autoimmune, I mean that your body's defense system is attacking itself by mistake. Do you see? Instead of using the word chronic, replace it with long-term condition. Right? Long-term conditions. Palpitations, replace it with racing heartbeat. Hypertension, high blood pressure. You see, simple words. Okay, now also remember, when speaking to trained healthcare professionals like nurses, paramedics, in a clinical context, what do I mean by clinical context? When they call to seek advice on behalf of a patient they are currently seeing, it is okay to use appropriate medical terms. But when speaking to carers, healthcare assistants, support workers who may not have medical training, stick to plain, accessible language. Now, what if a healthcare professional becomes your patient? So they are not calling you to speak about another patient, they are calling you to speak about their own health. They are now your patient. A doctor or a nurse or a paramedic practitioner is your patient. Avoid assuming they understand everything. So you can tell the patient, I know you're a nurse or doctor, but I like to explain things as if you aren't a nurse or doctor, just so nothing gets missed. Hope that's okay. Do you see that? All right. So please let your explanations adapt for the patient's or the patient needs. Now, number four, a judgmental approach was shown to the person. For example, you may not have done that intentional, right? But you may have done that unintentional. Of course, I know that each and every one of you are lovely doctors. But because English is not your first language, sometimes it may be difficult for doctors who English is not their first language, it may be difficult to do what? Phrase some terms or phrase some sentences. So, but let me give an example. A patient is worried about STI after unprotected sex, saying, please try to use protection next time. Sounds blaming, isn't it? A better approach will be what? We normally encourage condom use as it helps what? Protect against STIs. Would that be something you'd like to consider? Or a patient is coming for smoking cessation and you're telling the patient, well, Mr. Smith, you really need to quit now. He'll feel judged. So you can say, stopping smoking can really improve your breathing and overall health. Would you like to explore some support options today? Do you see that? So, saying it in a very sensitive manner so that the patient will not feel what? Judged. Now, number five, respect or sensitivity shown to the person was inadequate or inappropriate. Let me give an example. Let me give you an example because some candidates make these mistakes. Yes, when I do work with some candidates, they make these mistakes. Let me give an example. In a consultation for a patient with erectile dysfunction, a patient is coming in with erectile dysfunction. If you dive straight into questions like how is your sex life? Is your penis bent? No. You need to do what? You need to warn the patient. So, I would like to ask you some few questions about your sexual health. Is that okay? Then you go ahead and ask. Don't just go straight and ask, how's your sex life? No, give the patient a warning shot. The patient is not your husband or your boyfriend or your friend. Even if he's your friend, would you just go and ask your wife, look at the way your head is looking, or look at the way you're getting fat? No. He said, honey, I just want to talk to you. It seems like I've noticed you've been. It seems like you know your weight has been on the high side of recent. Is that something you've also noticed, or could it be that I am hallucinating? A sweet way to speak to your loved ones. You don't just go straight and dive into things. So warn the patient. You can't start telling the patient or asking the patient about their sexual lifestyle without what? Without warning. Without warning. So you don't just go and come and ask. If I'm the patient and you ask me how's my sex, I say, what's your business with my sex life? So warn the patient. I'm going to ask you some few questions about your sexual lifestyle. It will help me understand what might be contributing to this. Is that okay? Then you ask, are you sexually active? How is your sex life? Have you noticed any bend to your penis? And you go on from there. All right. So show respect. A patient with domestic abuse. Oh, is your partner hitting you? No, no, no. I'm going to ask you some few sensitive questions about your home life just to make sure we're not missing anything important. You mentioned that your husband was hitting you. I'm so sorry to hear that. Has he ever shouted at you or abused you verbally? Slowly show respect because these things are sensitive. All right? So show respect. So, number six, safeguarding concerns were inadequately recognized or responded to. A patient, a parent came to you, they're having substance misuse, and they have children at home. Once a parent is having is a parent is misusing substance that is illegal medication, illegal drugs, cocaine, etc., you should consider what? Safeguarding for the children. Consider what? Safeguarding referral for the children. All right? Or an older adult who appears frail and neglected. All right? So, did you think about self neglect or abuse? So, always be safeguarding conscious. Be safeguarding conscious. It's our duty as a primary care physician. All right? A 17-year-old told you, oh, doctor, I was raped at the age of 14, at the age of 13. This is serious safeguarding. Even though she's 17 now, when she was 14, that was a crime that was committed. Is she still at risk? Have you considered appropriate referral? Can you see? Always think ahead. Now, number seven, teamwork and or understanding of others' role was insufficiently recognized or responded to. So, a patient presenting with social issues such as loneliness, housing concerns, financial stress, or work related difficulties, did you consider involving the social prescriber who is placed to support non medical factors impacting health and well being? Can you see? Or a patient is coming in with chronic back pain. Did you consider referring to a physiotherapist? All right. So you must understand teamwork and role. That is why we are the head in primary care. So we understand what happens within teams. Good leadership. That is what they want to see from you. As a general practitioner, you are automatically a leader in primary care. Number one person in primary care. So this exam is judging that. It's judging your ability to make decisions, to understand your role, to understand other people's role, and to work as a team. Very important. Extremely what? Important. All right. So this is just an introduction to uh, an overview of the SCA. because it's important to understand what is expected of you. Because once you understand the exam, then you know how to prepare in order to pass. All right? Because of course, failure to prepare means that you are preparing to fail. All right? So, but of course, if you prepare well, then you are likely to do what? Do well in the exam. All right? So we'll continue. We'll continue. Don't worry. We'll take on some cases, do some few cases, talk about how to approach investigation stations, talk about how to approach pediatric station, talk about how to approach normal adult station, talking with a colleague who is medical, like nurse, paramedic practitioner, talking with another colleague who is non-medical, like carers, support workers, or talking to patient relative, etc. Ethical cases, all right, cases that you think that they may not be enough history and management is much bulky. So we'll talk about all these things. We'll go through all of them, go through over 120 topics, more than that. Lots of topics, all right? And then we'll finally end with mock stations, 65 mock stations, and we expected to do more, all right? So I want to thank you very much. Thank you very much for trusting us. Thank you very, very much for trusting us on this journey to help you in preparation for your SCA. We do not take this for granted. All right? We do not take this for granted. And that is why we are working hard to ensure we bring you all the important and vital information to ensure a smooth what? Success in your exam. Don't worry. The native novel get materials will offer, if you've not gotten it, please let me know, because this is needed for you to start reading, because it's bulky, so you need to start on time. And of course, if you're interested in more booklets, that is a different price entirely. Then we'll discuss that as well. So thank you very much. If you have any questions, please ask and we'll answer. Thank you. Thank you.